of us. We will certainly have opportunity for that down the road, but today is really for us to hear from you. Next slide. So that's my intro to the project as a whole. We also wanted to give a very brief high-level description of what we mean by value-based purchasing, because we, in the discussion questions that we sent out, we mentioned value-based purchasing, and some people are familiar with the term, others are not. And even just the term value is a term that we throw around a lot without necessarily thinking, what exactly do we mean by value? It can feel a little bit squishy. And what I really like about the term is that by definition, value means a relationship between quality as well as cost. It's oversimplistic, but one way that I like to start to break down value and think about like how we can improve value is in two categories. So if you think, if you say, all right, we're going to hold quality constant. If quality stays the same, what lever do we have to improve value? And the answer is that if you reduce costs, quality stays the same, you're going to improve value. On the flip side, if costs are staying the same, how do you improve value? You improve value by increasing quality. And so when we are thinking about how we pay for services, a lot of what we think about is, how do we incent providers to improve value, whether that is through improving quality or lowering costs or some combination of both. And the way that we pay for most of healthcare in this country is through fee-for-service. And fee-for-service in and of itself is not tied at all to value. It's tied to volume. And so the more you provide, the more you get paid, regardless of what is happening on the quality or the cost side. Next slide, please. So our priorities with value-based purchasing, we want to keep moving away from that fee-for-service end of things to a place where not only are we incenting the provision of high-value care, but that we also are providing more flexible payment models that enable providers to not have to do so much administrative work necessarily, that can encourage kind of team-based activities and the coordination that we know is so critical to good care that fee-for-service rates don't always explicitly pay for. And we're also interested in providers sharing some of the risk with MaineCare as a health plan and as a payer to be accountable for the cost as well as the quality of care that is being provided. So we already have a number of value-based purchasing initiatives in MaineCare. Every day we are talking about how to move towards more. Right now, when we look at the dollars that we spend, we estimate that about 20% of what we spend is tied up with our value-based purchasing programs. We're connected to them, and we have a specific goal within the department to double that 20% to 40% by the end of 2022. And so we will be tracking that goal and are excited to see our progress. Next slide. So another term that you may hear us use is alternative payment models, or APMs. And alternative payment models are basically the specific ways that you can pay for care in a more with a more value-based orientation. There's a great organization called the Healthcare Payment Learning and Action Network, or HCP-LAN. Their little logo is at the bottom of this slide here. And they have done some very impressive work over the last number of years working with stakeholders around the country to basically create a common language and common definitions for this path that I talked about that starts with fee-for-service, where there's no link to value, all the way to the future where you could have payments that are population-based. And so providers most definitely have accountability for cost, and there's always needs to be the quality component as well. And again, that flexibility piece that I mentioned. So there's a lot of steps along the way. And oftentimes, the first step within a service is to make that explicit link between the payment and the quality by looking at specific performance metrics and tying some of the payment to achievement of those metrics or performance on those metrics. So this is the path that we are on. And we are looking forward to the results and the recommendations of this rate system evaluation to help us identify services that might be good candidates in the short term for alternative payment models, as well as a longer term path as well. And wow, I think participation almost increased 50% since I started. So good to see such a fantastic crowd here this morning. I unfortunately am not going to be able to stay this morning, but I'm glad we've got great representation from the department. I will note that Olivia Alford, who is our Director of Value-Based Purchasing for MaineCare, has also joined as well. So I will turn it back to Julia so she can talk about the discussion topics for this morning, as well as basically our housekeeping rules for how the morning is going to go. And once again, your feedback is very important. In our second round of stakeholder engagement, we look forward to hearing more from you in terms of adequacy of rates. I will note that today we are focusing on rate methodologies. And so if you have comments, and I'm sure the folks probably do, on adequacy of rates, please save that until our next round of stakeholder engagement. And with that, I'll hand it to Julia, and thank you very much, everyone. Have a great day.
Great, thank you so much, Michelle. So on this slide, we have an overview of the 5 questions that we're going to be asking. We'll go through them one by one as we get to that. This is organized around the questions. So when the first question goes up, we'll ask anyone here to raise their hand in order to respond. Excuse me. If you're looking for the little hand signal, it can be a little bit difficult to find. It looks like a little hand. It's right above your chat box. It's right to the left of the symbol that looks like a megaphone. So sometimes the megaphone is a little easier to spot, and then you should have a raised hand right next to it. Our role is to introduce and discuss the questions and serve as a moderator. We would like commenters to keep their comments to the time that we set. We're planning for about 30 minutes for each question, depending on the number of participants that wish to speak under that question. Please keep your comments pertaining to the topic under discussion, and we will be recording and transcribing the meeting to make sure that all the comments are appropriately captured. Prior to commenting, if you could introduce yourself and the services that you provide so that we can tie your comments back to the specific services. And if you agree with someone, other points that people have already made, please just reference them and say you agree. There's no need to repeat everything that they said as well. We would just ask again that people limit their comments to the payment methodology and not the actual rate, because we will be doing rates at a different stakeholder meeting. Go ahead and move to the next slide. As we said before, the recording will be online within 24 hours, and the link will be on the MaineCare website. The phase 2 meetings, there will be able to comment on the phase 1 report, which will include the benchmarking rates, the catalog of existing payment methods, and recommend services as candidates for alternative payment models. If you don't wish to speak or aren't able to speak, you can always send us written comments at ratesettingeval@maine.gov. We'll give this email address at the end as well, and it's also posted on the MaineGov or the Maine website. So to kick off our first discussion is question number 1. This is, how well is the current methodology working for the services that you provide? Meaning, is it transparent and easily understandable? Does it create opportunities for you to be efficient or economical in the way you provide service? And does it reflect how you deliver services? So do you typically provide a bundle of services, but you have to bill separately for them? Or are you billing in increments of like 15 minutes when your services are at least an hour or several hours? And so it's more burdensome to bill in those smaller increments. We'll ask you to please raise your hand if you wish to speak. If you can't find or don't have the hand raising button, please chat to us in the chat box, and Jillian will be able to see that and unmute you either from the hand raising or through the chat box.
Okay, thank you, Julia. First up, I've got Susan Slick.
Good morning, Susan Slick from Acadia, and I oversee the behavioral health home program here. I want to say I do find the payment model to be very transparent. It's very straightforward, easy to understand the value-based purchasing, one payment per member per month. And I do believe that it forces efficiencies in practice, has a focus on preventative health care. The more efficient we are, the more clients we can serve. The one thing that I do struggle with is that the billing through the portal can be time consuming, because we also, and I think many agencies, have an electronic medical record. So we have to do double billing. We bill through the portal, and then we have to go into our system and drop a charge for accounting purposes. And that is pretty time consuming. And as far as the methodology, how does it reflect how we deliver our services? Since COVID, we've been serving people at a further distance. And I think there's going to be a challenge of billing, not being able to bill for phone calls only after COVID, if that's a consideration. Not everybody has access to Zoom. Services aren't available across the entire state. So we're afraid that we're going to have to drop some people that we have been helping through this really critical pandemic. And there's a struggle with some clients that don't want to talk on the phone. So not ever being able to bill for a text or email, or even through our portal that we have, our secure portal within our electronic medical record. We do a lot of work through that, and none of that is billable. So I think that might be where we struggle a bit. Thank you.
Thank you, Susan. Next up, I have Doug Townsend.
Yes, hi, good morning. Doug Townsend from Acadia as well. And my comments are regarding section 93. Although I would echo what Susan just said as far as the billing piece with BHH, it's the same for OHH. My comment on as far as the transparency, one of the things that we struggle with is because of the number of elements that we have to meet in order to attest, we end up doing sort of double tracking. We track all those services, and then if we're not able to meet and attest to the service to bill under OHH, then we have to go back and kind of piecemeal the services that were delivered. And the challenge for us on that is a lot of the services simply aren't reimbursable under Section 65. The dosing window with the nurses, anything that we do with check-in, it's really just the medical services and the counseling services that are reimbursable. So my recommendation would be just, if they're kind of like BHH, that if they're in OHH, they're in OHH. Certainly, there still needs to be a minimum, but I know with BHH, it's a very minimal requirement in order to be able to attest to the patient.
Okay, thank you, Doug. Next up, I've got, I've got Nate Miller.
Good morning. First, I'd like to just thank our hosts and Myers and Stauffer for taking the time to hear all of our voices. I think that's an important piece. So I'm Senior Program Director at Spectrum Generations, where we provide targeted case management, among other services. There's been a lot of talk this week about the struggles and barriers with fee-for-service models. And I think they're all applicable for this section. And I'd just like to say that I think case management is a really good candidate for value-based purchasing. And I really hope that this service is considered for that 20% increase. So again, thank you for taking the time to listen. That's all.
Great, thank you, Nate. Next up, I've got Natalie Childs.
Good morning. This is Natalie Childs from Assistance Plus. I just wanted to touch on Section 17 services. We provide daily living support services and skills development here. And over the last few years, we've found the program to grow increasingly burdensome around administrative pieces, specifically the eligibility process. There's a lot that's put on the agency as far as KEPRO submissions go, and there's a lot of follow-up as far as justifying the need of service, which is very time-consuming, and we found that many clients in service are not getting it. And additionally, there's been a lot of agencies that have stopped providing the service due to the administrative burdens. We also find that the authorizations are somewhat subjective, so it's just another piece that we struggle with. We also have found that the rate is not super transparent in the way that it doesn't clearly state in the regulations what the service specifically is covering. So again, it's somewhat subjective as far as what agencies are able to do and not do under these services. We do provide BHH services as well, and we've found, like other people that have spoke this morning, that the billing process is pretty extensive in needing to go into the portal and do the billing, and then our finance department also has to do the billing out of our electronic medical record system. So it's double the amount of work that we're doing there. However, with the BHH, we have found that the flexibility in the program is beneficial, and it does create opportunities for us to be more efficient. Yeah, I think that's it.
Thank you, Natalie. Next up, I have Lori Marchuka.
Yes, hi, thank you. I am the executive director for the Collaborative School, a day treatment program at Section 65. And we find that we provide very integrated services in our classrooms. So the payment is kind of complicated for us. You have social workers in the classroom, we have BHPs in the classroom, and kids that can be in crisis at any given time. So the fee for service of breaking that all down is complicated. And for like a crisis situation, like say you have a middle school or high school student, you can only bill for one clinician and one BHP. But when you've got a really dysregulated kid with mental health issues, it often requires more than just two people trying to provide containment for them. So that's difficult for us because, of course, if there are 3 BHPs and a clinician there, the BHPs aren't able to bill, yet they're providing services. Same would be true if our kids are getting OT services and a BHP is required. Again, the billing gets kind of complicated. And we have been told, I don't know if this is the forum for this, but that we should be billing in 1 hour increments. And sometimes like a mental status exam from a therapist or our clinical director might be 20 minutes to a half an hour. So in some ways, that's also difficult to not be able to bill on the half hour. I think for now, those are my comments. Thank you.
Thank you, Lori. Next up, I have Douglas Patrick.
Hi, this is Doug Patrick from Woodford's Family Services, Director of Behavioral Health and Case Management. Oversee adult case management under Section 13 for adults with developmental disabilities and also behavioral health home for children. And just some thoughts about how well the behavioral health home model has proceeded, and to urge some consideration for having that alternative for adults with developmental disabilities who only have the option right now of accessing targeted case management. In addition, the monthly rate is more consistent with the process of case management in the behavioral health home model, whereas we're tracking 15-minute billing increments in Section 13, which is quite burdensome. Also, for consideration of, and I know there's been talk about value-based purchasing and incentives, and it seems like the department has gone in the direction of having more of a penalty-based system in terms of care based on MaineCare claims data, but we can have some consideration for some incentives that are built in for providing care that is effective. Thank you.
Thank you, Doug. Next up, I've got Margaret Longsworth.
Hi, my name is Margaret Longsworth. I'm the Director of Mental Health and Clinical Services at OHI. And I'm going to speak about the mental health services that we provide, which are behavioral health home services, community integration, skills development, and we are in the process of closing our community rehab service, which I'll make more comment on. In phase 2, we used to provide daily living services, but again, I'll make more comments on that in phase 2. I would echo what some others have said from Assistance Plus and Acadia regarding the success of the rate setting or the payment method for the behavioral health home. I would also echo that I agree that the submission of the billing through the portal is cumbersome for a lot of the same reasons as others have mentioned. Some of the challenges with the Section 17 services relate to the specific requirements to get authorization if you are not somebody that has schizophrenia or schizoaffective disorder. It creates significant administrative burdens to justify the services that people need, and it creates barriers. People are just not getting those services. In the section that talks about DLS services, daily living, there's a prohibition from getting DLS along with skills development, whereas in the CRS program, there's an acknowledgement in that service that people periodically need both of those services at the same time. It seems a bit irrational to not allow somebody to have skills development and DLS at the same time if they need those services. I would also say that we have learned a lot through the behavioral health home program about the value of nursing support. And in the Section 17 services, you have to be an advanced practice nurse in order to be eligible to be a part of what people are spending in that service, where I think allowing a registered nurse would be critical for those folks in Section 17 who are providing medication support. That RN is really essential to be able to provide some person-specific training if somebody's needing support with insulin, and just the general support related to medical conditions. I think that's it for now. Thank you.
Thank you, Margaret. Next up, I've got Scott Tash from the chat.
Great, thank you very much. Scott Tash, with CEO of UCP of Maine. I'm also representing Maxby Children's Committee as well. So a few of the services I would like to touch on, starting with day treatment services. I would echo previous comments about being able to bill for a portion of an hour. However, I will say that day treatment billing in an hour unit does seem to work well in our center-based platform. As far as efficiency goes, it allows for reduced paperwork and outcome tracking, saving time and resources compared to a 15-minute block. It does, however, have a cap of 6 hours per day, which would be nice to have that extended to meet a traditional school day. No cap would be better, as those services are approved on a medically necessary basis. And those children who need a full day of support need to transition to other services, which causes more paperwork and other inefficiencies. Home and community-based therapy services. The clinical level of that service is, I think, adequately reimbursed on a per unit level. However, the geographic limitations and barriers sometimes make it difficult to fulfill all hourly needs and approvals. The ongoing availability of telehealth options would assist under the current model. Without that, I think a per member per month fee in addition to a per unit reimbursement might be helpful to consider. From the hourly behavioral health professional perspective on the home and community-based Section 65, operationally, it is a very difficult program to deliver and manage, as the work is typically performed only on nights and weekends. Because of that, the recruitment and retention of BHPs is difficult, and the BHPs would need extra incentive and pay on that. The quarter-hour rate in itself would be adequate, but given the limited hours and availability, along with frequent cancellation rates by families, make supporting even a part-time employment consistently very difficult. When the rate is reviewed, I think there needs to be an allotment for the turnover and continual training costs for the service to be effective. Section 28, rehabilitation and community support on the delivery of the service. It's very similar operationally to the Section 65 HCT program, where the services are typically provided on nights and weekends, and less being provided in our center-based program. Again, the per unit reimbursement, given the limited number of hours available to serve, make hiring and retaining staff difficult, particularly when there is a high level of cancellation rate from families due to weather, sickness, vacations, or any number of other reasons. Again, makes part-time situation consistency of wages very difficult. So a standard monthly rate or weekly rate on with a per unit and outcome-based rate might alleviate some of this uncertainty and help stabilize the workforce in that service. The service is also provided in the center-based system, similar to day treatment. The center-based delivery of the service allows for a per unit fee to be utilized much more successfully and more efficiently than the in-home and community setting. Cancellation rates are still higher than we'd like, but the center-based delivery allows for much more consistent hours for providers, reducing some of that turnover. And I would echo most of the other comments on the behavioral health home setting. The delivery of it, the per member per month, works well for this program. But I would also say that the billing system is cumbersome, and it does not connect to an existing EMR, which would make it much more efficient. That would be it. Thank you.
Thank you, Scott. Next up, I've got Heather Wiley. Heather, can you hear us? I'm going to go on to Pete Plummer.
Hi, thank you. This is Pete Plummer from Woodford's Family Services. I'm the COO, and we provide quite a few of the services listed for today's, agenda. And I'm not going to try to repeat what other people have said, but I want to highlight a couple other things on Section 28. I agree with everything that was said, so I'm not going to rehash that. But I want to add one thing. There's a priority wait list that KeyPro maintains that makes it really difficult to piece together full-time positions, which would really help us retain BHP staff because we could offer them full-time positions. And what I mean by that is we could have a BHP in a certain town that's treating a child, and maybe they're getting 12 hours a week. And then there's another child in the same town or the town next door, and they could be treating that child, but they can't pick up those hours because there's somebody above them on the waiting list that might be in the same geographic region as defined by KeyPro, which might be 4 towns over, and the BHP doesn't want to go there. So now I have a BHP that I can't offer full-time work when I have a consumer that's looking for those opportunities, and so they leave. Now nobody's getting service, and if they can just try to be a little bit more flexible with the priority list, that it would help us create part-time or full-time positions. It would help us be able to treat more people, and still, I know they have to figure out a way to get the person that's been on the wait list the longest. I know that that's an issue and a concern, but right now there's no or very little flexibility in that Section 28 service. Another service that I think there could be some administrative savings on is the TFC, the Section 97 Therapeutic Foster Care Appendix D, which we get lumped in a lot of times with a lot of other PNMIs, and it's a lot different service than other PNMIs because we're in the home of the TFC parent, and so and it is cost. I mean, it's not cost reimbursement. It's a fee for service program where we bill a per diem rate for the treatment, and there's a room and board rate, and with the per diem rate, it's a flat dollar amount. And in the foster care program, there's four different levels that we can pay the foster parent, and based upon the acuity of the child. No matter what we as a provider pay the foster parent, the daily rate that we get from the department stays the same. That's a flat rate. And we find ourselves advocating for the parents to get the reimbursement that they deserve, which is, typically a higher acuity because the rates are so low. And so we advocate for that, but we have to get permission from the department to pay the foster parents the higher rate to put them into a level of acuity, even to the expense of the program, because like I said, the rate we get is flat, but it's the right thing to do. So I know there's waiting lists in that program, but if we can do better for the foster parents, it'll be better for the program. And administratively in that program, what's really difficult is at the end of the year, it's the only fee-for-service program I know of where we have to file an annual cost report with all of the elements and submit globs of information. And if it is a true fee-for-service program, which it is, why are we doing a cost report? I'd like to have some consideration on eliminating the cost report for that program. Day treatment, we have a day treatment program also, and a couple thoughts there. We have BHPs, behavioral health professionals, that provide service, and the BHPs also provide the services in Section 28 in the HCT program, and the level of certification or education needed should be the same for all the BHPs and all the different programs. For the day treatment, they need to have 90 credit hours, or they can't be credentialed to operate in day treatment. That same BHP could have, a high school degree and all the training that the BHP certifications require, and operate in 28 or in the HCT model, which the HCT model was a recent change to 65 to make that a little bit more consistent. So I ask that in rule, if they could make the BHPs consistent throughout programs so we as employers can use them within all the same programs. And how they came up with 90 credit hours, I don't know. There's not a lot of 90 credit hour people running around out there. You either have 60 credit hours as an associate's or 120 hours, with a college degree. So by default in day treatment, we end up having to hire college educated people based upon the 90 credit hour rule, and it just messes things up. The other thing that needs to be reconciled is the IEP, the education plan, and the treatment plan in day treatment in section 28. There needs to be consideration, and I know there's a new rule, section 106, that's been proposed, that's out there floating around, and within that rule, there's an attempt to cap the treatment hours for day treatment and or section 28, to what the IEP says. Now, in the preschool programs for the 3 to 5 year olds, which, are covered by IDEA, the same as any K through 12 program, we have to do all the same amount of educational work and support for these 3 to 5 year olds, writing the plan, the meetings, and everything. And the IEPs typically are capped at 15 hours a week for these kids. And for treatment, they're typically given 30 hours on the ITP. Well, Section 106 goes into place. It's going to cause a whole mess of extra burden for the preschool providers that are going to have to look at EPSDT to get the kids the work that they deserve and have earned, and so that needs to be looked at in context also. And I know that's a DOE issue, but if DHHS and DOE can get together and figure that out, that would be a wonderful thing. Let me see if I have anything else. I took some notes, and plus everything that everybody else said, I agree with, would be very helpful. So thank you.
Okay, thank you, Pete. Next up, I've got Andrew Tarenko. Hope I pronounced that right.
Yes. This is Andy Tarenko. I'm the Maine Director of Living Innovations, and I'm also representing MAXB, the Maine Association for Community Service Providers. I'm the board president and the chair of the Targeted Case Management Committee. I'm speaking on section 13, and I guess I just want to tie the methodology to the rules. Section 13 has 5 or 6 disability categories, and the IDD adults is an entitlement. So it's written into another piece of legislation, into law, that any IDD adult who qualifies for case management is entitled to it, and the state has to provide it. All of the other services don't have that, yet the rules are all the same for all the disability categories. And all of those disability categories have a different division of the Department of Health and Human Services that oversees them with varying degrees of intensity of oversight. So in terms of how the methodology becomes into practice, as much as it's transparent and everybody has to follow the same rules, there are 4 or 5 different divisions that are overseeing the same set of MaineCare rules. So I think that causes problems. And if there are going to be 4 or 5 different divisions, there probably should be 4 or 5 different sets of rules, and certainly a different set when it comes to IDD adults if there's an entitlement and requirements. So, I think I want to acknowledge that a value-based purchasing and behavioral health home model for children has been successful, and I think is a good concept. In the case management world, it matches very well, but all the other services are don't have access to that. So as comments prior to mine, I think there's an opportunity there for value-based purchasing and case management, but I want to warn everyone that because of the way things are set up and the way the methodology works, there are different ways that targeted case management is delivered, and some of them are delivered in a more care management model, and in many other states, case management is actually delivered in a care management model. And so those care management models are cubicle based or phone based and outpatient based, where the individual, the client, comes to the case manager rather than the case manager going to the individual. And so the methodology allows for that variance, yet pays the exact same rate in all services, except, again, with the value-based purchasing behavioral health homes for children. I think that those are my comments for the moment. Thank you very much for allowing this opportunity.
Great, thank you, Andy. I noticed that some people still have their hands up. If your comment has been completed, if you could lower your hand, that just helps us keep track. Next up, I've got Elizabeth Cameron.
Good morning, everybody, and thank you for the opportunity today. I want to, I absolutely agree with several of the comments previously, so I won't reiterate them here, particularly the comments made by Pete and Scott. One thing that I wanted to focus on in particular is that at times, so I work at the Margaret Murphy Centers for Children, and we provide Section 65 and Section 28 services primarily in our setting here. One issue that we run into that results in a loss of reimbursement for services provided is that some of the information required in terms of determining medical necessity has to be collected prior to the student beginning with us. So we obviously need to collect that information in order to justify that services are provided, but then we can't recoup that information or that billing for that time spent. If we were to postpone a start date for a student, let's say, in order to gather that information, it creates a barrier and a limitation on their ability, the consumer, to access the services that they need. So that's a difficult situation for us in our setting. I absolutely agree with the comments about how difficult it can be at times to align the educational or IEP related needs and the ITP related needs, and that there is a lot of redundant paperwork. So hopefully in the future, we're looking at a better system for both of those. The only other comment that I want to make is more specific about Section 28 services, in particular, the board certified behavior analysts covered services. In joint guidance issued by both DHHS and DOE, we have been directed to record the BCBA services on the IEP, and we understand that IEP services, in order to be reimbursed through MaineCare, must be reflected on the student's IEP if they have one. There's a misalignment, though, between the nature of those covered services under the medically necessary Section 28. Apologies for the noise. We have a classroom moving past my door. So there are several different covered BCBA services, and on the ITP, some of those are indirect services. It might be data review and analysis. If we have to reflect those services on the educational document, there's no way that that educational document is as flexible or able to keep up with a possible increase in unit need if a student is in crisis or has a significant change. I hope that's making sense, but it's essentially static on the IEP, and it is not static on the ITP because those needs change, and there's no way to anticipate the incredibly complex needs for an individual student over a CSR period or an annual period. So I'll leave it there, and we'll have additional comments later. Thank you.
Okay, thank you, Elizabeth. we're running a little bit short on time, so I've got a couple comments here. I've got Scott and Pete I'm going to get through, and then we will move on to the next topic. And if we have time, we can pick back up if anyone else has additional comments on this topic.
Hello. So this is Scott Hayward. I'm the State Director for Pathways of Maine. And my comments are, so starting with behavioral day treatment, the issue of the 1 hour billable unit can be challenging. We work in our program primarily with children with autism. And the idea of having a therapist sit with a nonverbal child with autism for an hour straight is, it's not good for the child, and it's not really good treatment. And so some more flexibility would be really beneficial, I think, for the program, for especially clinicians to be able to conduct shorter sessions as the child needs. We also provide the service to very young children, and they also, it can be a struggle to try to conceptualize a therapy session as 1 hour with those kids. In terms of home community-based treatment, this is my own perspective. There's a lot of challenges that fee-for-services creates that are probably not necessary in the service. Some relate to quality, and that the 15-minute unit productivity becomes a large part of the supervision, because it's how, as a company, you survive and generate revenue. And so the quality of the supervision is always impacted by productivity requirement of staff, and especially when you maintain full-time staff, that productivity requirement that you have to hold them to can be very high and can be challenging. So a different rate structure, I think, would be more supportive of the service, especially considering that many of the sessions are 4 hours long. And then for, I think that the other issue related to that is the challenge of the hours that are available for staff to work with. I also would love to see more flexibility in our ability to assign cases off of the wait list, so that we can create more full-time opportunities for people, and hopefully retain more people as well. And those are my comments. Thank you very much.
Okay, thank you, Scott. Next, I think Pete wanted to make one more comment on section 13.
Yes, I did. Thank you so much. This is Pete Plummer from Woodford's Family Services. In section 13, for the adult population, one of the services that we perform is representative payee for many, many, many consumers, and that's a non-reimbursable service. And a lot of these consumers used to be case managed by the state of Maine, and the state, has asked providers to take them over, and we have, and what I find is it really is a very, very beneficial service to these consumers, but it's not allowable as far as billable time. So the case managers spend a lot of time, and I brought this up with, when we used to have ODES meetings a lot. They always say, "We'll go back and check on that, and we'll go back and check on that," and maybe now is the time to check on that. And if the rep payee service could be billable time, it would allow providers to even maybe take on more cases that need to be transitioned out. It's I can't tell you how much time we spend doing rep payee work. So that's just a request when you're looking at the type of services delivered, to have it bundled into that rate. Thank you.
Okay, thank you, Pete. It looks like we might have time for one final comment here. Michael Mitchell.
Hello, my name is Michael Mitchell. I'm the Chief Executive Officer at Crisis and Counseling in Augusta, and we provide predominantly Section 65 services. I echo much of what has been said so far, and again, also thank you for the opportunity to give this feedback. My additional comment is more specific to the crisis services. In particular, mobile and residential, there was a transition some years back away from a cost-shared contract to a fee-for-service. And there were indeed efficiencies that we had to realize in that transition. But we've also realized that during that period of time that it doesn't truly reflect, a fee-for-service reimbursement system doesn't truly reflect the nature of that service, given the changes in demand, as well as disruptions in the residential services in milieu, so that bed capacity is not the only way to consider that service. So I'm hoping that that will be considered in future conversations. Thank you.
Okay, thank you. I think we're going to move on to the next question now. If you still have a comment on this question, we can circle back towards the end if time allows. So if you could please lower your hand if you still have it raised, so we can switch to the next question. Thank you.
So the next question is question number 2, and it's really looking at whether your payment methodology is creating the right incentives, or conversely creating disincentives for quality of care, access to care, supporting primary and preventative care, integration of care, care coordination, how members use services, and if it's structured in a way that avoids abuse and fraud. So if you would like to speak on this question, please go ahead and raise your hand. Or if you cannot find where to raise your hand, if you chat to us, then Jillian can see that as well.
Okay, thank you. First up, I've got Kate Marble. Kate, can you hear us? Okay, it looks like Kate, we may not be able to hear you. Oh wait, I'm hearing something now.
Can you hear me now? Okay.
Yes.
All right, sorry about that. So yes, I'm Kate Marble from Health Affiliates Maine. I oversee Section 13 Targeted Case Management for Children, Section 17 Community Integration, and Section 92 BHH. And I just wanted to talk a little bit about some of the quality pieces to this question. There used to be the ability to have a stronger transition between either levels of care or duplicative services. We used to be able to do a warm handoff, and right now, if we do a warm handoff with another section of policy that is seen as duplicative, one of us goes unpaid essentially for that warm handoff. So that was just something I wanted to mention. And then with BHH, I do agree that it's a really great program, and that the payment methodology works well. I would only say something about the quality measures, that we have to be careful about what quality measures are set, because right now they only measure one small sector of the work that we do, and for only a portion of our clients, and it often relies on claims data from other organizations that are beyond locus of control, in terms of when they use the correct codes, if they bill in a timely manner, for example. And so when you have limited control over the documentation for the quality measure, this can lead to provider frustration and reduced goodwill between the partnering organizations. And then just one thing for potential for abuse is that the system could be potentially abused if a provider chooses to overly limit access of the client to the service. For example, saying they can only have a half an hour of service a month, for example, instead of what their actual plan of care should appropriate for time, because there is a financial benefit for that. However, we do obviously have to provide some sort of limitation on the amount of time someone accesses care in order for the payment model to be affected. So that's all I just wanted to mention. Thank you.
Thank you, Kate. Next up, I've got Susan Slick.
This is Susan again from Acadia. I oversee the BHH program. And I definitely think that the payment methodology creates the right incentives for coordination of care, integration of care, pays for team meetings. Where we struggle with is what the caller before me spoke about. We don't often know when somebody's open with another BHH program, and we're finding it increasingly with OHH programs. So we provide the service, and if it's provided near the end of the attestation period, we just don't get reimbursed because we have to wait until the PA comes back to be told that, oh, they're open with another provider and you can't have a duplicate service. So it would be nice to have some way to figure out ahead of time before we enter into the service with somebody if they're open with another provider. And I think with OHH, some of the outside OHH programs, they're coding it with case management, and our clients don't even always know that. So they're like, oh, I don't have a case manager. And then come to find out after the PA is submitted, they do when we do some digging and call KPRO, and it's with OHH. So if we could figure that piece out, that would take some administrative burden off as well. That's it. Thanks.
Thank you, Susan. Next up, I've got Ken Olson.
Hi, this is Ken Olson. I'm Executive Director for Kids Piece. And at Kids Piece, we provide several of the services that are, that are listed here. I want to talk a little bit about access to care and using standardized rates, such as what we see in home and community treatment. I want to echo Scott Hayward's comments about the challenges associated with the wait list. That program is, I think we all know in Maine that access to those services, particularly in the rural parts of our state, is a particular challenge, that the wait lists in those regions are quite high. I can tell you that, Kids Piece provides similar services in other parts of the country where we see different payment methodologies for similar services. And among the things used in some other places include add-ons to rates for offsite, for an offsite service. So there's basically a rate for delivering the service, and then there's an add-on to that rate that you can bill based on the travel distance. In other places, travel costs are included as a billable expense. And exploring those kinds of methodologies for home and community treatment might alleviate some of the access issues there. On the subject of treatment foster care, I agree with the comments that Pete Plummer made in the earlier segment, but also wanted to make the observation to those of you who are studying the rates for therapeutic foster care in Maine compared to the rates in other states. There's a particular challenge there that you folks need to be aware of, which is that treatment foster care is not defined in the same way in every state. Maine uses a Medicaid model to deliver treatment foster care. Not every state does. Kids Piece provides therapeutic foster care in 7 or 8 different states, and we see vast differences in the level of acuity of the kids that are served by that program, depending on the treatment, depending on the payment methodology in those states. We also take measures of the level of acuity of kids served in our therapeutic foster care programs. And in Maine, where Medicaid is a payment source for that service, the level of acuity tends to be much higher than it is in similarly named programs in other states. So there would be a potential pitfall to comparing treatment foster care rates in Maine with treatment foster care states rates in, say, Indiana or New Hampshire, Vermont, for example. So those are my comments. Those are my comments for now. I have something else to say about that with respect to value-based purchasing, but I'll hold off on that until that segment.
Okay, thank you, Ken. Next up, I've got Scott Hayward.
This is Scott again from Pathways. Thanks so much. Some things I wanted to say regarding question 2 are number 1, the DHH structure. The way that it's currently structured is that there's a rate that's paid per month, and then there's basically a disincentive if you're not meeting certain outcome requirements. I would propose that instead a structure consists of a flat rate with incentives that you earn beyond that by continually hitting outcome measures. The other thing I wanted to address was access, especially as it pertains to HCT. That fee-for-service requires a provider's focus to be on the number of hours provided, as that is what drives revenue, rather than a number of families served. A weekly rate or even a monthly rate in that service would allow providers to focus more on the number of families they're serving. It would also stabilize the revenue so that we could better project our ability to serve rural areas and the costs that come along with that. And then the question of fraud. The fee-for-service structure that we currently have requires us to pay staff a diversified rate, so a lower rate for non-billable time and a higher rate for billable time. This is necessary because if the session is postponed or canceled, there needs to be an incentive for the staff person to reschedule that session and not just backfilling this time with non-billable time, as that would be really expensive for us to try to manage, and we just don't have the money to have a standard rate for both billable and non-billable time. So as a result, there are situations, I'm sure, where people are, because of that, are incentivized to achieve the higher rate and put billable time that they didn't actually bill. And that's another piece of administrative burden that we have to have multiple systems in place to check for that, constant contact with families, make sure they're getting the services that are, that are being billed for, and those sorts of things. Another thing that a weekly rate or a monthly rate would help mitigate to some extent. And those are my comments. Thank you.
Thank you, Scott. Next up, I've got Nate Miller.
Thank you. This is Nate Miller, Senior Program Director with Spectrum Generations. My comment is about case management. There's currently an executive order that broadens the cap on how many consumers a case manager can carry on their caseload. And the reason for that is to improve access to that very important service. My fear, though, is that when caseloads increase, it may affect quality of care. And the direct reason for that executive change is related to the rate. And I know we're not supposed to talk about the rate amount at this point, but part of the problem with the methodology of the current rate is that it doesn't account for increases. So it's just the same year after year. I also wanted to talk about access to care. I think a good example of how it could be improved is representative payee services. That's still a service that we're providing for our consumers. It's not mandated for case managers, and it's not a reimbursable service. So a lot of agencies don't offer that. But it costs money for us to administer it, and we hope to be able to continue that service. But if we keep trending in the same direction, it's going to become more difficult. So I do believe that a new methodology would increase quality of care and access to care. Thank you.
Okay, thank you, Nate. Next up, I've got Michael Mitchell.
Hello again from Crisis and Counseling. Again, about the crisis services. As far as quality of care, access to care, et cetera, one of the things that we've realized is that, especially during the pandemic, that there's an expectation of crisis services capacity to respond to a wide range of complexities clinically. And the rate currently, or the system currently, is essentially flat no matter what the complexity is. And so therefore, if you have low and high acuity and complexity of care, as well as preventative efforts, all of those efforts are compensated at the same rate, where in fact the cost and the level of clinical involvement is different depending on the particular presentation. And so something to consider going forward to incentivize preventative and making sure that effective use of lower levels of care before inpatient or more expensive ED contacts, that there are ways in which that could be incentivized in the cost structure. Thank you.
Thank you, Michael. Next up, I've got Scott Tash.
Thank you. I think this will probably be fairly brief, but again, on the Section 28 and the in-home Section 65, again, the per unit methodology, given the limitations of how and when we can provide the services, generally nights and weekends, and the impacts that ultimately has on staff recruitment and retention, limits really what our families and clients, how they have access to those services. So I think that methodology is really shortening those opportunities for families. And also on the avoidance of abuse and fraud, specifically in Section 28, while it's not necessarily just the methodology of payment, the addition of the EVV system for Section 28, it's designed to reduce fraud, but will add several additional hours of work for multiple people in the service delivery and the payment process, with additional documentation on client signatures and the actual billing and the progress notes. It must log into the service and EVV and do the same thing, including client signatures. So if that piece regarding the duplication around the service delivery could be limited, that would be helpful. Thank you.
Okay, thank you, Scott. Next up, I've got Lori.
Hi, this is Lauren. I'm the Executive Director for the Collaborative School Day Treatment Program. And I just wanted to really talk about the integration of care and care coordination. And some of it goes back, I think someone else mentioned, related to the IEP, but would be helpful if there was some dialogue between the two. Right now, we have a psychiatrist that is a consultant, a couple, like four to 6 times a month. She's on site and provides management for any kids that are in the program. But the IEP doesn't allow for, and there's no for psychiatry services. So we just basically have to absorb her costs, but we think it's imperative that we have her for the quality of care. And then when you get to, and that's true a little bit also for speech and OT, because OT, the things that is allowable for billing is just a few sessions here and there, particularly around sensory integration. And the same is true for speech, is that it's really limited to what is billable. But care coordination is when a family, which many of our families also have HTC or other services involved in the home, and periodically we need to get together to work with so that, during the day and at home, we're giving the same message to the families. If we go out to do any meetings in the home, it's not billable. If the in-home support people are there. And it also, there's no mechanism for billing for coordination of care. If a member's not there, we can't bill any of that coordination, and it's really affects quality of care. And providers, there's no incentive for providers to, other than good quality treatment. Otherwise, there's no incentive for providers to be in a dialogue about an overarching treatment plan for the student and the family. Thanks.
Thank you, Lori. Next up, I've got Katie Rutherford.
Hi, thanks so much for your time. I'm the Executive Director at Franny Peabody Center. We provide case management services for people living with HIV under Section 13. And I just want to speak briefly about access to care, specifically as it cuts across the behavioral health home program. We have several clients who have mental health challenges who also need very specialized case management for their HIV care. And we have gotten into the position where clients have to choose between being enrolled in a behavioral health home program and, having to choose between their mental health and their specialized HIV care because of those duplication of services from a billing standpoint. We obviously try to do as much as we can and not get reimbursed because we understand the need for that specialized care. But that is obviously not a sustainable model financially for us. And as a lot of people experience mental health issues who are living with HIV, we see that that's likely going to increase in terms of that duplication. I also just want to say briefly from the side of having to enter or get prior authorization for all the KeyPro units, that system does not integrate with any of the billing functions. And so between waiting for people to become active in MaineCare, we're providing those services regardless of that activation, and then the timeline of having to submit that retroactive request in KeyPro so that we can get reimbursed for the services that have already been delivered. There's a very short period of time for the case manager to have to submit that request, and oftentimes just due to human error, it gets missed and there's no way to capture those units. And so we have a staff member who is constantly monitoring the units that are available under KeyPro or what has or has not been submitted that we're kind of waiting on activation to submit through KeyPro. And so that entire shuffle becomes a full-time job where KeyPro is not, that system doesn't count down the units or alert you in any way to what may be running out to submit a CSR. And so just the lack of the integration with the billing systems is really frustrating from an administrative standpoint. And it's definitely putting a burden on the agency and thus access to care for our clients. Thank you.
Okay, thank you, Katie. Not seeing any new hands, so I know Andy Taranko, you wanted to go back to the previous question and have a couple comments. So let's do that now.
Thank you again. I missed just one point regarding section 13, and that is with the home and community-based settings rule coming into play in the next 2 years from CMS, that the expectation of conflict-free case management again adds an added layer to the methodology that is already instilled in the IDD adult system that isn't necessarily in the other disability categories. And I also wanted to speak in regards to section 28. Again, I'm the Maine Director for Living Innovations, and we provide section 28 services to kids. And that quite a few years ago, the disability categories were loosened in section 28 to allow basically so that kids wouldn't fall through the cracks between section 65 and section 28. And one of the unintended consequences of this is a lack of specialized providers. And I know that's something that the Office of Aging and Disability Services, OCFS, has been working on recently. But that is the other thing that the methodology or the unintended consequences of that. Great. I appreciate the time.
Okay, thank you, Andy. I'm not seeing any new hands for question 2. So I think we'll move on to question 3.
Okay, great. So this question is really looking at equitable payment methodology. So is the payment methodology for the services you provide equitable to the methodologies for services delivered by other provider groups? So if you look across your service area, are providers generally treated equitably in terms of payment methodology? And this could be in how fee schedules are determined and updated, the administrative burden, or incentives for quality and access. So go ahead and raise your hand or chat to us if you can't raise your hand, and we will start working through the comments for this question.
Okay, so first up, I've got Pete Plummer.
Thank you. Yeah, the equitability question is real important. Again, I'm from Woodford Family Services, the COO. I forgot I was supposed to introduce myself. The equitability for the day treatment program in the Section 28, it's the school-based services actually, and really more so for the 3 to 5 year old population. I might have mentioned this before, but I just want to mention it again on equitability because it's really, really important. We receive two types of payments for school-based services for programs that are operated in the state of Maine. One is the treatment, which comes out of Section 65-day treatment or 28, rehabilitative services. And that right now is equitably shared amongst the providers. The problem is with the Department of Education. I know this is a DHHS thing, but the two departments really need to work together and to make it equitable. The sending schools for K through 12 pay a tuition reimbursement for, all the academic needs of those children, which is very, very appropriate. For the 3 to 5 year olds, the sending school in essence is Child Development Services or DOE. They send $0 of tuition reimbursement, and it makes the equitability of maintaining staff is, I know we're not supposed to talk about rates, but this is just a process thing, an equitable thing. And so it really puts preschools at a huge disadvantage in not receiving any of that money, but having to conform to all the IDEA and IEP standards, and then coupling that with the reduction of hours on the IEP from Child Development Services, or the capping of 15 hours a week, whether or not these kids deserve 30 or not, is very problematic. So if the rate that preschools are losing, or not being able to get tuition reimbursement, if that could be enhanced through MaineCare, or if MaineCare could talk to DOE, to make it equitable, something, there should be a discussion there. Thank you.
Thank you, Pete. Next up, I've got Andy Taranko.
Thank you again. I'm speaking about Section 13 and specifically the administrative burden. I made this comment before. I want to be a little more specific that the administrative burden and administrative oversight from DHHS, from the Office of Aging and Disability Services, in relation to the payment methodologies, seems slanted. So the other divisions that work with targeted case management don't put the resources in that the Office of Aging and Disability Services does, and it creates an added layer of administrative burden for the case managers who are doing the direct billing, the more time that they have to spend doing administrative tasks. And again, I'm connecting this back to it's an entitlement. So the department is required to document a lot more things for an adult with IDD potentially than they have to in some other disability categories. And yet the payment methodology is exactly the same. It's paid on a quarter-hour basis. And so when you add on top of that, again, then more adults with an intellectual disability or autism also require a rep payee, which is another administrative burden that Pete mentioned earlier, that it seems a little lopsided in terms of how the department is delivering a service that has the same set of rules, MaineCare rules, and same payment methodology. And again, I'm sort of separating that from behavioral health homes, which is a different payment methodology, and again has some definite benefits. So appreciate the time.
Okay, thank you. Next up, I've got Margaret Longsworth.
Hi, this is Margaret Longsworth from OHI. I just want to say that with the fee-for-service programs, if the rate is not adjusted in a meaningful way over long periods of time, when you have increasing costs related to staff wages, when you compare that to other programs that are cost settled, where you can apply for a rate adjustment to help keep pace and make sure that you're able to hire people, that does not seem equitable and creates a lot of problems for this fee-for-service programs. Thank you.
Okay, thank you, Margaret. Next up, I've got Ken Olson.
Hi, Ken Olson, Executive Director at Kids Peace. Echoing Margaret's comment with respect to cost settled programs, the therapeutic foster care program is a PNMI, and I'll make this comment when we talk about residential, children's residential as well. But that section of the PNMI rules is not cost settled, whereas other sections of the PNMI rule are, and that strikes me as being a difference that's not equitable to those services. Thank you.
Okay, thank you, Ken. Next up, I've got Scott Hayward.
Hi, thanks again. So again, Scott Hayward from Pathways, State Director. So the comments that I have for this question are, number one, it's not transparent or clear how rates are set and what the methodology to determine rates is. There's also no standard for how they're updated. So there's no opportunity for through a regular process or anything like that for providers to seek regular increases for increasing costs. Admin burdens are frequently added with no rate adjustment. The most recent example is the EVV process, which even in the federal law, there's an allowance for rates to be increased to offset the additional administrative burden, but there's been no opportunity for us to providers of Section 28 to pursue that or receive that as that system is implemented. And then, from my perspective, fee-for-service model, especially as it pertains to community-based high intensity services, is actually disincentivizes access to service by requiring a hyper focus on the amount of units delivered to an individual client. So so those are my comments for this question. Thanks again.
Okay, thank you, Scott. I'm not seeing any new hands or anything in the chat. Oh, never mind, just got one. Next up, I have Scott Tash.
Thank you very much again, Scott Tash, UCP of Maine, CEO and representing MAXB Children's Committee. I just wanted to touch additionally on Pete Plummer's comment about the equitability around tuition, and it circles back to his original comment about the BHP certification. If the BHP 90 credit hour is to align with the K through 12 EdTech 3 90 credit hour requirement, there should be some equitable reimbursement around tuition or similar fees, and that should be consistent based on those similar requirements with similar services being provided. Administrative burdens, specifically around Section 28. Folks have touched on this a little bit as well, but getting services approved is not easy to understand. It's time consuming and is all non-billable time for 28 unless the client attends, which you cannot really do. It's not realistic. Completing the intakes, request the units, set up the paperwork. None of that is compensated for given the current rate methodology and reimbursement. The wait list, again, continues to be an issue regarding administrative burdens, trying to work through that and trying to get clients transferred between services appropriately. When you have providers who are familiar with the family, if an agency, for example, offers HCT or day treatment, specialized 28 and 28, it'd be ideal to be able to have a client working with the same providers in all three services or two services if they were able, and not have the family have to feel like they were starting over each time they made progress or not, or move to a higher or maybe a lower level of service needed. The current system actually discourages families from switching services as their child makes progress because they're afraid to lose familiar staff or go back on a wait list for an indefinite amount of time. Again, on administrative burdens on behavioral health home, the billing system is an additional administrative burden, so I won't beat that drum again. Thank you very much.
Thank you, Scott. Next up, I've got Natalie Childs.
Hi, this is Natalie from Assistance Plus again. I just wanted to touch on Section 17 services again, specifically around the administrative burden compared to other programs that we offer. So other services such as the BHH, even Section 13 services, they have very specific eligibility criteria. And what we found again over the last several years is the eligibility criteria for Section 17 has become increasingly burdensome and subjective, and it's very difficult to prove the need for eligibility for the clients that we serve, and which again has caused a lot of agencies to stop providing this service, which has decreased the level of access for people that need it. And just in regards to the quality of this service, I mean, it's hard to discuss quality without discussing the rate, but over time, we've found that it's incredibly difficult to hire good quality staff to provide this service when they're able to go to other places, with the same level of education and make more money per hour than what we're able to offer under the current rates. So again, I really wanted to emphasize again the administrative burden for Section 17 services.
Okay, thank you, Natalie. Next up, I have Brandy Farrington.
You hear me?
Yes, we can.
Okay, I apologize. It took me a moment to unmute. This is Brandy Farrington from Kennebec Behavioral Health. I just wanted to note with regard to community rehab services, the challenges when that was set up, it was sort of set up with the rate was very much like a PMI, a daily rate. And there are a lot of constraints that go along with that regarding the number of staff to individuals that are able to be seen, and the number of hours that the staff need to be in the actual office building. And so with those things in mind, as we start to, we know there's a large wait list for PMI services. So folks who are unable to get into PMI often end up in a community rehab setting. And as we do more and more community rehab out in the community and not necessarily in one building where historically community rehab services have been provided, we're doing more and more out in the community. There are associated costs that go along with that work out in the community and the travel and again relative to the staffing ratios and time spent on site. There are some considerations with regard to that I think are evolving and should be considered. Thank you.
Thank you, Brandy. I've got a few hands still up here, so if you're complete with your comment, if you could put your hands down. Or if you want to say something else, please raise your hand again. Thank you. Next up, I've got Mark.
Hi, this is Margaret Longsworth again from OHI. I just wanted to piggyback on what was just said about the CRS service. While we're going to talk about the PNMIs tomorrow, OHI runs PNMIs, and we have often used the CRS program to get people out of, transition them out of the PNMIs. And as the rate has not kept pace to really keep CRS programs going, and those services become harder to find, the administrative burdens associated with trying to get people out of the PNMIs efficiently and effectively has really been impacted. So, my comment really kind of crosses over those two services that are being discussed on different days, but I want to make it clear that the CRS service is absolutely critical to the proper functioning of those PNMI services. And without it, we really turn off one of the primary ways we get people out. And that therefore makes it difficult to get people back in who are waiting in hospital settings. Thank you.
Okay, thank you, Margaret. I'm not seeing any new hands or any new comments on this question. So I'm going to go on to question 4.
Okay, great. So during this time, we do sort of question 4 and 5 together. The first one is talking about whether your methodology is consistent with value-based purchasing, or is it consistent with any other value-based purchasing approaches that you have in place with other payers or that you're aware of through either other payers or other programs in other states? And then are there any administrative requirements, coding, billing, reimbursement? You guys have talked about this a little bit, but related to the methodology MaineCare specifically places on you that are burdensome. And this would be anything in addition to the comments we've already collected about administrative requirements. So we'll go ahead and again ask for chats and hands if you would like to speak.
Okay, first up here, I've got Scott Tash.
Great, thank you again, Scott Tash, CEO, UCP of Maine, representing Maxby Children's Committee as well. Specifically around Section 65, home and community-based therapy. In value-based purchasing, in respect to that, there are no overarching goals around HCT from a statewide perspective for providers that everyone is trying to meet. For an example, a measure could be a percentage of readmissions to a residential facility within a certain number of days after treatment if they go into HCT. There's nothing like that around the value and incentives. There are really no major incentives to have high value programs as far as compensation and the methodology goes. We have, on the UCP side, we have invested in evidence-based treatments and trained our staff. However, the limitations around the reimbursement and consistency of hours contributing to the turnover makes this investment have very little return. The value of training our employees and providing the quality services to families is what really drives us to use the evidence-based practice and maintain the high value programs. But the extra time we put into training and supervision are not compensated for or acknowledged in the methodology by anyone outside of other service providers or families. I would say something very similar within the Section 28 value-based purchasing. Aside from specialized rates being higher than regular 28, there aren't, again, any incentives to have those high-value programs. Again, what drives us is providing that training and quality of service to the families and having that high-value programs, but the time and supervision is not compensated for. Regarding behavioral health home, outcomes and the client progress are measured, and the outcome-based incentives would be welcomed. But as others have mentioned, currently there are really only consequences for the measures that we don't achieve. and those can be pretty significant. So I think there's more work to be done regarding the appropriate measures that behavioral health providers can actually impact. Thank you.
Thank you, Scott. Next up, I have Susan Slick.
Hi, this is Susan again from Acadia talking about BHH. One of the administrative burdens that I find is in the VMS portal, there's a lot of really good data that could be pulled on ED usage, medications, PCP encounters, but it's not in real time. So that's a struggle for us to keep on top of things with some of the quality measures. And I think it would also be great to show like the value of BHH. I have anecdotal stories that I could tell how BHH has saved our hospital money, has saved MaineCare money, but pulling reports out of the portal and getting some real data to show is a struggle. It's so much of a struggle that we don't go in there as often as we probably should to pull everything because it's just really cumbersome. And there's a certain window of time that that data is in there and then it's gone. So we have to remember to go in and pull it during the window that it's all in there, save it, and then try to manipulate it into something that is meaningful to show others. So I think that that's an administrative burden that I'm hoping could be fixed because there just isn't enough time and the reimbursement rate just doesn't afford somebody with that skill level to go in there and pull those reports. Thanks.
Thank you, Susan. Next up, I have Nate Miller.
Thank you. This is Nate Miller with Spectrum Generations. Regarding case management, I would definitely say yes, there are administrative requirements that are burdensome. There seem to be regular new mandates. For example, case managers have been tasked with additional follow-up on reportable events and national core indicator surveys. Important things to do, but not reimbursable. So I think case management would be a great candidate for a per member per month model. And I think along with that, consider that case management can be different depending on the consumers. Some of it is more intensive, like case management for individuals with intellectual or developmental disabilities. Thank you.
Thank you, Nate. Let's see. I'm not seeing any more comments in the chat or the Q&A. I've got, here we go. Sadel Davis.
Hi, this is Sadel Davis. I am the Director of Behavioral Health Home and Case Management at UCP of Maine. I would like to say that I agree with all the comments I've heard about 92 and the administrative burdens as well as the burdens with measurements. Specifically to 13, I think the current methodology is not consistent with value-based purchasing. For children's case management, it's based on pre-approved units. And what we found in the 92 model is that some cases are higher needs and some cases are lower needs, but they kind of all even out. And if you added into that limits about how much service you were approved to get paid for, as it does in 13, then I think that absolutely impacts our ability to truly impact the quality of care and spend time digging into that data. That's all.
Thank you, Sadel. Next up, I have Scott.
Hi, me, Scott Hayward from Pathways, State Director there. This comment is specific to behavioral health homes, and we provide that or a similar service in many other states, and Maine is the only state where we have a face-to-face requirement in order to attest for that. That does have an impact in terms of our ability to reach clients that are in rural areas. So, that's in terms of how the system compares to, what we deal with other payers in other states. That is a significant difference for that service. And that's my only comment. Thank you.
Thank you, Scott. I'm not seeing any more comments. Pete, is your hand still up from the last question, or do you have something you want to comment on?
No, it's up. I'm sorry. I don't know. I thought I did. I agree with everything everybody said.
Okay, thanks. I'm not seeing any more comments or hands up. Julia?
Okay, great. So that is the end of our questions. If you could go to the next slide so we can have the email address up. If you have any questions that, or any comments, excuse me, that you didn't have the opportunity to speak to, the email address is ratesettingeval@maine.gov. Please don't hesitate to email them. As we're here at the end and we have a little bit of time, I just wanted to open it up if there was anybody who had wanted to speak and weren't given the opportunity, or if there's any information that you feel like is really important for us to know that has not already been conveyed today. We'll take a few minutes here to go ahead and take those comments. So if you would like to say something that you think is important for us to know that hasn't been said, go ahead and raise your hands or chat to Jillian so that she can unmute you.
Okay, I've got Katie Rutherford.
Hi, Katie Rutherford again. I'm the Executive Director at Franny Peabody Center. I just wanted to say a quick thing about value-based purchasing, and again, the correlation to targeted case management under Section 13. If there is going to be any sort of transition to a value-based purchasing model for targeted case management, if there could just be really careful consideration around what clients experience and how we define positive health outcomes and what those incentives look like. We serve many clients who are struggling with chronic homelessness, very complex medical conditions, substance misuse, and a number of co-occurring needs. They can be in case management with us for years and really depend on the support from their case manager to stay adherent to their life-saving medication. So just to kind of put that out there, that there's a really high level of care that is provided, and we don't always see those quote unquote positive health outcomes. If it can be defined as continued engagement in care, with how those tiers may be developed, I just think that's important to note. Thank you.
Thank you, Katie. Next up, I've got Pete Plummer.
Hi, thank you. I may have missed this at the introduction. If I did, I'm sorry. I know that this is being recorded and that's great for people to go back in and listen, but are there minutes being taken or notes for future reference, as we get down the road, that we can go back and re-look at all these wonderful ideas that people have had?
Yes, there are recordings that are being posted publicly, and then there will be transcriptions as well. I'm not completely sure when those will be available, but there'll be a link posted on MaineCare's website.
Thank you.
Okay, next up I've got Dale Hamilton.
Hi, Dale Hamilton, Executive Director of Community Health and Counseling Services. I just wanted to note that, one, I appreciate the opportunity to provide feedback, but I would also note that in a lot of ways it's kind of generalized feedback, and it's really difficult to provide specific recommendations regarding the rate methodology for value-based purchasing without understanding the design of that model. So I would just throw out there that at the point at which the state has determined that a particular VBP model for a specific service type is warranted, and they've developed that at that point, stakeholders should have the opportunity to give specific feedback on the methodology to ensure that the methodology aligns with what's being created with the VBP, because there's no one model for VBP, and without knowing that, it's difficult to give you exact feedback that will ensure that the rate methodology works for that particular construct.
Okay, thank you, Dale. Next up, I've got Mallory Shaughnessy.
Hi, can you hear me? Okay, Mallory Shaughnessy, Executive Director of the Alliance for Addiction and Mental Health Services. And just a general sort of statement around methodology, excuse me. Even if we have the best of methodology that accounts, and I mentioned this in the other session, but even if we have the best of methodology that accounts for all the pieces within a service, the assumptions are also critically important. And those really need to have input on as well. So if you have a service and you have assumptions around how much transportation on an average week, or how much time the paperwork takes, or any of those types of assumptions, we have seen that very much skew the rate to where it doesn't sustain the service. And so just to keep, making sure we're thinking about that it's not just even the methodology of what we account and how we account it. It's the assumptions we make as we're building that rate.
Okay, thank you, Mallory. Next up, I've got Margaret.
Hi again, this is Margaret Wadsworth from OHI. I just wanted to reinforce what Dale Hamilton just said. The payment methodology is a very different thing than the rate setting methodology, and we really do need time at some point in this process to be really exploring the rate setting methodology as a separate subject. Thank you.
Thank you, Margaret. I'm not seeing any new hands or anything in the comment or chat box.
Well, thank you everyone again for joining us today. We really appreciate that you took the time this morning to come and speak to us. Again, rate setting eval at maine.gov if there is something that you didn't have the opportunity to tell us that you'd like for us to know. So please don't hesitate to use that email. And I hope you all have a good rest of your day. Thank you again.